Good afternoon, everybody. Thank you for joining the next edition of the New York State HIMSS Chapter virtual meeting. Today, we're going to be discussing analytics to improve outcomes, patient engagement, and resource allocation. Next slide, please. For the logistics for the folks that are out there, for the attendees, live captioning is available. You can hit the CC button and be able to look at the titles at the bottom of your screen, and you can handle your video controls. For all of those out there, the Q&A function will allow you to be able to place questions into our moderator, who can then bring them to the presenter as time permits. We're going to hold all questions to the end of our session. This way, we'll be able to get through the presentations and the material that has been prepared by our great presentation crew. And if you run into any difficulties, please just click refresh, come back in on your browser, and we'll be able to do it. This event is recorded and will be available. Right now, we put down within a week, but we can usually get it up within 48 hours. Next slide, please. If you're not a member of HIMSS today, please come and join the chapter. We have a full calendar of events. Click on the New York HIMSS chapter. Come join us. Come join us for our next event that we have coming up later this month. Next slide, please. Let me take the opportunity to introduce our moderator, Mr. Michael Haas, who is from RSM US LLC, who is our sponsor for today. Michael, it's all yours.
Thank you, Tony, and good afternoon, everybody. Thank you so much for joining us this afternoon and during your lunch hour. As Tony mentioned, my name is Michael Haas, and I'll be your moderator during this presentation. Please feel free to put your questions in the chat. I will be monitoring them. If you have a specific question for a certain panelist, please put the name of the panelist in there and we can direct the question directly to that individual. A little bit about me. I've been in healthcare for about 10 years now, worked in the revenue cycle space. I've worked in the behavioral health space, and most recently in the electronic medical record space doing some project management. So I'm very happy to be here with you guys, and we have a great presentation for you. Next will be Dr. Jamie McLaughlin.
Thanks, Michael. So my name is Jamie McLaughlin. I'm the Healthcare Analytics National Lead for RSM. My background is I have a PhD in computer science and big data analytics. I've been doing data science for too long, and I've been fully dedicated to healthcare analytics since 2011. And the two things I'd like to point out is that one, the healthcare analytics I do are really not primarily focused on giving you the most elegant reports or dashboards or tools. Those things can be important, but really we're focused on performance improvement. And for that in healthcare, that means clinically, operationally, efficiency, and financially. And so that's really what we do, is try to help organizations improve by getting more value out of their data and information. The last thing I'd like to point out that's not on here that we're really proud of is I've published 28 papers. 13 of them we've published with healthcare physicians or leaders. And the idea behind that really is when we create something, we like to look at what worked well and what didn't, and see what we can use to help more organizations get better in the future. And we like to publish it and make it a peer reviewed and get input and work together with our physicians and really create reusable solutions that are part of the healthcare informatics research. And to thank you, Michael.
We'll go over to Dr. Martins now, please.
Good morning or afternoon. My name is Tim Martins. I'm a pediatric heart surgeon at Loma Linda University Children's Hospital. I've been in medicine for about 20 years now, and at Loma Linda for about 5. I have a PhD in tissue engineering, but throughout my residency and time in the lab and then working as an attending, I've always had kind of an interest in data and how it can be effectively used and integrated. And 20 years ago when I started, everything was just handwritten notes and pretty sloppy stuff that no one could read. And you managed to master your signature so that you would never get sued because no one knew who was signing anything. But as the field has migrated over to the electronic medical record, there's been some issues, but it's opened up a wealth of opportunity as far as capturing data and then using it to do all the things that Jamie just talked about, improve your efficiency, improve your outcomes, improve your retention, et cetera. So I'll talk a little bit about how we did that in the congenital heart disease space.
And now we have Dr. Bauta.
Hi, good morning or good afternoon, everybody, depending on where you're joining us from. I'm the Chief Data Officer and Chief Compliance Officer for Mercy First. It's a human service organization in New York City, primarily in Brooklyn. My background is in health services research, primarily global health, epidemiology, and public health. I've done a lot of work both here as well as internationally, thinking about health systems and how do we improve not only individual outcomes, but primarily population level outcomes. So I'll be talking a little bit more about that work and what I have been doing within Mercy First as far as different projects. Pleasure to be here.
And last but not least, Dr. Rabinowitz.
Thanks, Michael. My name is Dr. Betty Rabinowitz, and I am a general internist at my core and where my heart lies, but I spent 25 years in practice as part of the University of Rochester's Center for Primary Care. The last 5 years there, I was the medical director for the Center for Primary Care, and in that context, got very much involved with our initial value-based contracts and realized that in spite of the blood, sweat, and tears we had put into the EHR, there was very little clinical data available to us at the point of care to help us make rational decisions about patients and populations, and got really immersed in developing a prototype of a population health tool. Later, that tool got commercialized by the university. We spun out a company that created a full-fledged population health tool. That company got acquired by NextGen Healthcare, which is one of the leading healthcare technology and services EHR companies, and I currently am their Chief Medical Officer. I'm going to talk today about use of social determinants of health to impact both the individual level and the population level outcomes that we are so focused on and have become so called to act on these days. I'm looking forward to a great session. Thank you.
Thank you, everybody. Nick, we can move on to the next slide. Here's just a little table of contents, which we will be talking about today. And for anyone on the call that will be looking at the recording or those who are not present and need to look at the recording in the future, these will be the topics we will be hitting on, doing an overview of analytics, using some use cases into some population health and social determinants. So we have a full slate for everybody this afternoon. So enjoy your lunch, and we'll move over to Dr. McLaughlin to start us off.
Thanks, Michael. You can go to the next slide, please. And the next slide. So I wanted to really start kind of at the basics, and that would be, what is analytics, right? If that's our topic. And I think a lot of times that's confused with reporting in the healthcare space. So we have a lot of data, right? And anybody that's worked with data in an EMR or in hospital or even a provider space knows what a report is, and they probably have a way to request reports, and those could be really useful. Without reporting, data is not organized at all. But to me, analytics is a step beyond of the report that just tells us, what happened and with one set of rules yesterday. It's really designed to give us insights and to allow our users to ask questions, right? And those questions can be things that go beyond just what is happening or what happened, but why did it happen, and maybe what we could do different. And you can almost brainstorm with a good analytics solution. If you can go to the next slide, please. So what I see again and again in virtually every healthcare client is I have yet to find a health system that has too little data. And now, maybe 20 years ago, today everybody has too much data, right? We record every temperature, every note, everything a patient eats, every phone call, and getting any insight of that is really, really hard. And what we see is more and more tools and more silos, and you might have a tool that's really good at OR or really good at endoscopy or really good at scheduling, but it becomes so hard to know what tool to use for what, and we have so many different tools. And what we hear again and again is that people across the health system don't know where their data came from on the reports they get. They don't know to trust it. They don't know numbers they see in meetings where they came from. And the data really isn't integrated at the most basic level. This is things like your time and attendance and your cost and your risk management and your patient experience all is probably in a different system than your patient charts and your electronic medical records. And then you could take that a step further. What else could I get value from? You know, I have a client that got an amazing amount of value out of the weather. Like the actual temperature outside and the weather forecast made a pretty big difference to a major county hospital's emergency arrival. You know, Dr. Betty brought up the value of social determinants of health. There's so many extra pieces of information that we can join to our patient records to get further insights. But just adding more data will make our problem harder. It won't make it simpler because most hospitals, most health systems already have quite a few silos of data that aren't well organized. And you end up with multiple versions of the truth. And this comes down to, like, you can go to virtually any health system and say, you know, what is my length of stay? What is my discharge by service? And you'll get more than one answer for pretty basic questions. You know, what service discharged them? Is it based on the provider that discharged them? Is it based on the diagnosis that they had? You know, what happens if an internist discharges a heart attack patient? Is it cardiology or is it internal medicine? Right? And so we end up with multiple versions of the truth, and this makes it harder and harder for the data to be trusted. So our goal is to get accurate, trusted data that's easy to understand and to get it to the right person at the right time to help them make informed choices. That's really what we're trying to do here. We're not trying to automate. We're trying to get information to the people who make the decisions, both for the patients and the organization. Next slide, please. Okay, so this little chart here at the top, right? Once again, what is our goal? What is the goal of a provider or of a hospital, right? It's to provide the best care to the patients who need it and within the resources that we have. So I put 5 bullets that to me are the analytics categories that solve that. To provide the best care, we need quality. We need to understand what is the best care for this disease? What is the best care for this event? To provide it to the patients, we need patient engagement. Communicating with patients in a way that they understand is extremely important. And to get it to the patients who need it, we need care management. We need to understand, what do patients need and what do they not need? And to do it with limited resources, we need to optimize those resources and we need to be efficient. I know we don't have a lot of time. I'm not going to go through this huge slide down here below, but my point here is one of the things I really like about healthcare is, you know, usually when I hear win-win, I think I'm hearing something from sales that isn't true, right? But there really are a lot of opportunities that are win-win in healthcare, right? If Dr. Martins does more surgeries, then he saves children and his health system makes money, right? If I do better preventative care, my patients have better outcomes, and the insurance company probably pays less over their overall life for their care. If I reduce the length of stay for my patients in the hospital, they're less likely to get hospital-acquired infections. They're less likely to come back and I've reduced costs, so I've helped my organization financially, and I've probably improved patient experience because most people don't really like to be in the hospital. So that's just some examples of how analytics can help solve all these different integrated problems, right? We're trying to be more efficient to provide better quality with less resources. If you go to the next slide, please. So one question I think is really important here is just to understand who needs care. We brought up care management. Now I'm going to start with the really simple examples. You'll hear from the physicians on this call the much more complicated examples, right? But you know, some of them are very basic. We know who needs wellness care, right? Most of us know that if you're over 50, they recommend you have a colonoscopy every 5 to 10 years. You know, most females know that mammograms are a very important way to detect breast cancer, that we should regularly monitor our blood sugar and our cholesterol. That, you know, I'm not going to get into a vaccine debate today, but preventative care would certainly, the CDC would say COVID-19 vaccine would be very helpful for that. Then we go into what is needed for chronic disease management. And, you know, there's a lot of research out there that tells us, you know, if I'm a COPD patient, I need regular spirometry. I need to see how I'm breathing. If I'm a diabetes patient, I need my feet examined and my eyes examined to make sure I'm not getting neuropathy. You know, one that relates to me, you know, I had a heart attack in 2010. Right. And so we have under here echocardiogram and cardiac stress test. So I was feeling some chest pain earlier this year. And I went to my cardiologist, who I'd not heard from in a long time. And he did a full stress test and he did a ultrasound of my neck or something. And the answer is everything's great. But my point in that is he said, yeah, it's recommended to do that every 3 years. And it had been about 3.5 years. Nobody had ever told me it was recommended to do it every 3 years. Nobody called me and said, it's been 3 years since your stress test. Maybe you should come in, you know, and the research shows that if we do that, it keeps patients from having heart failure. It saves lives. And yet even a very, very good cardiology provider is not actively telling patients or engaging them so that they know when they need to come in and have this life-saving preventative care. I think we kind of all know acute care, right? If I have a heart attack, if I have a stroke, I go to the hospital. I can't really, that's a whole different discussion on how to treat all those the best. So I'm going to kind of skip over that one and go to, you know, more of elective intervention. So what treatments do my patients need to improve their quality of life? You know, maybe they have knee pain, maybe they have hand pain like I have. You know, maybe they need carpal tunnel surgery, maybe they need, you know, better physical therapy for their hands. Whatever that is, we can use data to try to figure out how it is and what those patients need. If you could go to the next slide, please. So how do we identify the people that have those needs that we just said? So one really simple one that applied a lot because of all the canceled appointments during the disruption of the pandemic is you canceled an appointment. You didn't come in, or we called you and said, we're not doing this right now because of the pandemic. We should probably follow up and bring you back in. There was a reason you scheduled that appointment at the beginning. Orders, right? So we've seen this a lot with telehealth. You know, I've gotten a call about my child, right? He had a telehealth visit and they ordered some blood work and their blood lab wasn't open June of 2020. And it was about 3 months later before I realized that we never brought him in to do his labs, right? So if we have orders, labs, images, echoes that haven't been done, obviously that's a care gap, right? Some of these are pretty basic. Wellness, we talked about colonoscopies. Chronic disease, we talked about the cardiac stress test. We talked about colonoscopies, right? There's thousands and thousands of metrics and evidence-based research that tells us what treatments we need. And we just need a way to organize that so we can actively take action on it. And then care paths. And, you know, we've probably, most of us have heard of inpatient care paths, like how quick do I, you know, get you a balloon if you're having a heart attack? How quick do I get you antibiotics if you have sepsis? But even on the ambulatory side, like I worked with a back pain and, you know, they go and they say, well, we want you to do physical therapy. Well, now am I going to follow up and see if that physical therapy is working for you? Or am I just going to hope you come back if it doesn't, right? How am I have this kind of Visio chart, this care path, on what I think the best treatment for the problem you're experiencing is. How am I engaging you to make sure that you know what you need to do to stay on that path to best care? And then risk analysis, and we'll kind of hear a little bit about that today. But you know, there's lots of things, like if I'd had a poor event on that stress test, that we could take we can actively look to see if if a patient is in danger of a negative event, and we can use analytics to identify who's most likely, and that might be clinical. You heard social determinants of health. That might be, you know, that my job situation or my housing has become unstable, and that perhaps I'm in risk of a negative event because of non-healthcare concerns, but it's still my health that's at risk. If we go to the next slide, please. All right, I'm not going to spend too long on this, but obviously if we're going to bring in these patients, we need to make sure we have the space to do them, right? And everybody talks about do more with less, and so we need to make sure we have the resources. And how do we do that? Well, data could really help us. We want to make sure the patients show up, that they know when to come, that we know how long they're going to be there, that we schedule them efficiently so they don't wait a long time. Surgeries especially, we can, it's amazing analytics. We just did a very small hospital, 22 beds, and we were able through analytics to add about 1 surgery per operating room per day. That's helping a lot more people and creating a lot more revenue, even for a very small organization. You know, when do we need nurses there? When do we need staff? How do we know how many people we're going to need? So there's a lot that analytics can do just to make sure we're ready to help that patient in the best way. And this little chart on the right is just to reemphasize how important it is that the patient experience is right. The patient health is not just always knowing the right treatment. It's making sure the patient understands why we're giving them this medicine, what they need to do, that we're communicating with them, that we're not making them wait and angry where they don't want to come in and get the treatment and the health care that they need. We can go to the next slide, please. Okay, so I want to just bring this up. So our dashboards, our analytics are designed to identify the needs and organize the patients. And then you could use that, but the outreach is really important. So this example here, this is demo data, obviously, but this is a pretty simple metric that a lot of providers, both in behavioral health and in primary care, use. Right? We want to make sure that a patient is not having a problem with alcohol, right? And so we give them counseling, we give them medications if they are, and we ask them regularly. It's a pretty simple metric. It's out there, it's a public metric. And so what this is showing us is this same metric that most providers are already doing. We can then look at that 24.85% of patients that weren't positive, that weren't in compliance, and we can drill down on them and see why did they not meet this metric. And then we can reach out to them and bring them in. And you could do the same thing with colonoscopy or anything else, is we can use the same metrics we're already calculating to identify care gaps, engage those patients, understand the care they need, and try to improve their quality, because these metrics were created to improve outcomes. And the last point I want to do on here, so you see how it says dashboard filter, right? So maybe I only do colonoscopies. Maybe I only support Dr. Smith. So these interactive analytics can be designed to get a view that we really want, that our user wants. And so for a doctor, that might be to review the patient's chart and see if they need care. But for a scheduler, that might be to understand what language they want and what location they want and call them. And this outreach up here at the top is really important. Do they like to be called on the phone? Do they like text? Do they use their chart with their EMR? Does the provider need to call them, or is it enough for a nurse to call them? What do we need to tell them? So it's both about understanding their needs and their communication preferences. And I think you'll see in the next part that Dr. Martins is going to discuss how we've been able to integrate that within the electronic medical record so that it's easy for providers and patients to see. And there's lots of other ways that you can integrate it as well. So that's pretty much what I wanted to talk about as an overall way of using analytics to start addressing patients' needs. And we'd like to turn it over to a much more complex example that follows the same sort of process, which is Dr. Tim Martins, and how to use this to find congenital heart patients who need care.
Okay, thank you very much, Jamie. We're going to do kind of a deep dive on a very specific example of relevance to me in my practice, but I think it illustrates both some of the logistic hurdles we went through in setting this up, and then at the end of the tunnel, once we reached it, the advantages it has over some of the approaches that were either in place or not utilized. Next slide, please. Okay, so congenital heart disease poses a number of challenges for organizations and for their providers. It's the most common type of birth defect out there is a congenital heart defect. It occurs in just short of 1 in every 100 live births, 8 in 1,000. Over a quarter of the patients that are diagnosed with congenital heart disease will require either a surgical or a catheter-based intervention. About a third of those are in the first month of life, and the fetal diagnosis rates, even with the best of prenatal care, usually only capture about 50% of the congenital heart disease out there, meaning patients who actually have a 20-week ultrasound and go to their OB-GYN and do all the appointments, will have about 50% of their babies will be prenatally diagnosed. The other half, they fail a SAT screen or a check before they go home, or sometimes even they go home and then come back pretty sick because we missed the diagnosis, and then we make it later in life. Challenges that are unique to this population. Again, the interval between the diagnosis and the treatment can range from days to years. So if you have a prenatal diagnosis for something you know needs to be fixed in the first month of life, you can organize your care, have that baby delivered in a tertiary center that can perform the surgery and then do the surgery. However, if you miss that diagnosis, that patient's going to go home and may end up, hours from care and be an emergency transfer. Or we might diagnose something simple like an ASD or a VSD, a hole in the heart that doesn't need treatment possibly ever, or if it does need treatment, can be done, when the child is 2 years old or 5 years old. That presents a challenge because that child, unless they stay plugged into your system, can very easily disappear, be lost to follow-up, and then come back again when they're sick with their relatively straightforward defect having not been treated. Another thing that's common is repeat interventions, meaning there are some surgeries where you just have one surgery or one catheter intervention and then you need nothing for the rest of your life. They represent a minority of congenital heart disease. Much more common scenario is multiple interventions over time, whether that's 2 or more surgeries or a surgery and trips to the cath lab and whatnot, but repeated procedures that require pretty tight surveillance to make sure that they happen. And then the final hurdle, that's the transition. A lot of times children, their parents will make sure they see their pediatrician and their pediatric cardiologist, but then they go off to college, they turn 18, they think they're invincible, and they don't go to a doctor for 20 years with something that needed regular follow-up. And again, the chance for kind of declining health is significant. Next slide, please. To put it in perspective, this is the most recent report from the AHA, and this is based on somewhat old data, but based on the 2002 CCD codes. They estimated there's roughly 1 million people running around in the United States with known congenital heart disease, divided almost evenly, 500,000 children, 500,000 adults. There's a pretty wide spectrum as far as, again, the severity and the need for intervention and follow-up. As an example, again, something like an ASD or a VSD, there's 200,000 of each of those. And if the surgery or the catheter-based intervention was successful or medical management was successful, that's a relatively straightforward population with not significantly different survival rates than people without congenital heart disease in the long term. Contrast that with single ventricles, and while they represent a smaller portion of what's out there, those children require usually 3 surgeries by the time they're 2 or 3 years old. About 60% of them are alive at the age of 5, and then of that population, roughly a quarter of them will go on to significant heart failure and ultimately need transplantation. So that's a very vulnerable population that, without very tight follow-up, is going to have poor outcomes and high resource utilization. And then you have some much more common things like tetralogy of Fallot, TOF, that lie somewhere in the middle. 60,000 patients with tetralogy that we know of running around. Most of them required surgery in the first year of life, and it has a very high survival rate with a relatively normal life expectancy and quality of life. Shaun White, the Olympic snowboarder, is a good example of a tetralogy patient, but roughly 50% of those patients, so 30,000, are running around that will need a pulmonary valve replacement at some point in their age 10 to 25. And that's a surgical procedure or a catheter-based intervention, without which they will have right heart failure and a poor life expectancy. So kind of a very broad spectrum from the very simple to the very complex, but even the simplest of things do require pretty close attention. Okay, next slide. So how do we keep track of these patients now? Traditionally, it's mainly through registries, but the fundamental kind of shortcoming of these registries is that they tend to focus on a small subset of the entire congenital disease population. So 2 examples that are very widely used are STS and the IMPACTS database. STS is a surgical database that is a voluntary database. Roughly 75 or 80% of the centers that do congenital heart surgery voluntarily report to that system. It's a very robust system. The data element definition manual is about 450 pages and has some 500 fields that are very well defined. The statistical analysis and weighting that went into it has about 15 years of publications and validation behind it, but it only captures patients that underwent surgery. So if you're born with something that ultimately needs correction when you're 2 years old or 5 years old, you're not in that database until you've already been operated on. Similarly, the IMPACT database is the same thing for the cath lab, but if you're in need of a catheter-based intervention but haven't had it yet, there's no room in these registries to place those patients and track them. In addition, they tend to be third-party vendors that don't allow for much customization, and they're really not focused on the population as a whole. As is a common theme across hospital systems, there's limited integration with the EMR, if any, and then limited integration with other similar systems. So, okay, next slide. So, as a young surgeon just joining Loma Linda, my primary interest was to kind of increase the market share, first and foremost for very, very selfish reasons. More patients means more surgeries means more cases for me. And when you're starting out, really, it's almost a Malcolm Gladwell type phenomenon. The more surgery you're doing, the more reps you get in, the better you're going to get at it, and the quicker you're going to get there. But the other important component to that is outcomes in virtually every procedural-based specialty, and they're very, very tightly tied to volume. That's been shown over and over again. Again, the more reps, not just your surgeons get in, but your ICU gets in, your operating room gets in, your nursing staff gets in. The more they see and the more they do, the better they get at taking care of these patients. And so there's a very, very clear link between surgical volume, cath volume, ICU volumes, and overall outcomes for these patients. So anyway, I landed at Loma Linda and I had a very simple question for the cardiologists here. And I said, how do we track our congenital heart disease patients, and how do we make sure that they're following up and we're capturing all the surgeries and caths that we need to do, and we're maximizing the quality of the care we give? And the answer I got was, well, we know our patients very well. We know when they come and we know when they don't. Being from New York and landing in California, I tried to be polite, and rather than cry BS, I said, all right, well, let me do a little digging. So we're a little bit lucky for pediatric heart disease. 99% of the diagnostic information and the diagnoses are made off of echocardiography, especially in the younger children, but even at all ages, echo is the first and foremost way to do it. And it captures everything just about, short of vascular rings and a couple other kind of small subsets. So I went to our IT department, just like Jamie talked about, and I said, okay, I want to find out how many echoes we've done on patients that have come back with congenital heart disease. And It sounds like a simple question. It probably took about 6 months of back and forth and formulating the query and getting results that made no sense. But at the end of it, they managed to generate a report within our EMR for me. I was not very facile with the EMR or manipulating 11,000 records buried in a table. So the best I could get was a CSV export, and not that it's ideal, but at least I was a little bit better at playing with that. But the end result from all of this was I had 11,000 echoes in a massive Excel spreadsheet, and all I did was randomly start at, I think, echo 4,328, went through 100 consecutive echoes, and then literally just opened up the EMR in every single one of those patients. And if I believed that we know our patients and they always come back, then I shouldn't have found any issues. But the pessimist in me was proven correct. So of the 100 consecutive echo patients, just from from 1 month in January, 27 of them were diagnosed, treated, and did not need any further follow-up. 35 had residual lesions, meaning they were either operated on or had something that was being medically managed and monitored that warranted at least annual surveillance, if not more frequently. And from that 35, 15 had missed their scheduled follow-up appointments, and 10 of them had gone more than a year without any follow-up. And on top of that, we found 4 patients that had operative lesions that needed either a cath or a surgery procedure, and they hadn't gotten it, even though there was clear documentation in there that they needed it. So of those 4, since that report, one of them had a pulmonary valve replacement, one of them had a transitional canal repair, one of them had a huge ASD that ended up getting closed in the cath lab, and there was a single ventricle in that most vulnerable population that needed the 3rd surgery, and for whatever reason hadn't gotten the pre-surgical cath or the surgery itself. And that was just from 100 consecutive echoes in the month of January. You can imagine if you went through all 11,000, what it would turn up. Next slide, please. Okay, so armed with that information, then I went to the hospital and said, obviously, there's some gaps and there's some things we can do better here. I'd like to develop some sort of population management tool for our congenital heart disease patients. And the predictable reply was, yep, that sounds like a great idea. How much is it going to cost? And can we do it here? And it took a little bit of negotiation back and forth, but just taking the 4 surgeries that were missed and the contribution margin from those on the hospital side, we were able to convince the hospital to do 2 things. One was to try and develop this tool, and second was to hire someone whose 50% clinical time and 50% would be spent toward filling in, populating, and managing this tool. We'll go into the dashboards and some of the features of it, but the key components that we used, we identified what we called high yield kind of user-defined fields. Jamie spoke to this a little bit. Something as simple as a diagnosis in an EMR these days can be found in 10 different places and can be a laundry list of items that's 100 long, and literally anyone who can get into the EMR can add things to it willy-nilly, and what you get is an overwhelming amount of conflicting, incorrect, and unreliable data that, for a variety of reasons. So we thought it was best if we created a diagnosis dropdown that had limited access to only providers familiar with the patient and the diseases would be the only ones able to put that kind of high yield diagnostic information in. We also had what we called a repair status. Again, I'll show you an example on the next slide that just classified the patients as hadn't had any surgery, had surgery with a complete repair and no residual lesions, were in that single ventricle pathway, so they've had surgery 1 of 3, 2 of 3, 3 of 3, whether or not they had an implant that required surveillance. Now, you can go on and add a billion of these fields, but one of the things that we needed to balance was minimizing the impact on workflow while we maximize the data integrity. So by limiting which providers could manipulate this, we were pretty confident that the data integrity would be good. But we also were asking providers on the front lines in clinics, for example, surgeons and cardiologists, to take an extra 30 or 45 seconds to use these drop downs, because my attention span's about that long. If you ask me to do something that takes 2.5 minutes on every clinic patient, I'm going to flat out say no thank you. So minimize the workflow impact, maximize the data integrity, And then the final part was, once we had this information in there, combine it with the scheduling information. So not only identify what congenital heart disease specifics the patient had, where they were in their care pathway as far as surgery, catheters, pre-op, post-op, and then whether or not they were actually seeing the specialist they needed to see. And then utilizing that information along with an algorithm to then identify and prioritize the patients that are most at risk for bad outcomes, being lost to follow-up, and kind of who the high priority patients were, so that you could focus your outreach team on, starting at the top, who's most likely to die without care in the next 6 months, and then working backwards to, who can wait a couple years. All right, so next slide is the example of a type of dashboard that tries to address this. Okay, so again, this is a mock-up so that we're HIPAA compliant. But you start at the top with just some basic numbers. So this is a dashboard that's identified 3,000 some odd patients that are suspected of having congenital heart disease based on whatever. In our case, it would be an echo diagnosis off the Q codes. What percentage of them have been assigned a primary cardiologist? That was one of our drop downs. So this is roughly, half of them, give or take, have been assigned a cardiologist, and then some percentage of those will have actually seen a cardiologist, which leaves you a pretty large population of patients needing follow-up. And I would say these numbers are very, very typical of what we found at Loma Linda, meaning we've identified 13,000, almost 14,000 patients with known congenital heart disease, and we've been reining them in, but we've still got about 6,000 that have yet to be plugged into appropriate care for a variety of reasons. It's better than the 10,000 when we started doing this, but there's still a lot to be done. And then just if you want to track volumes or whatnot, you can have how many have come in the last 12 months sort of metric for you. Okay, and then you can stratify them by, how many have been 1 to 120 days versus, 3 months, 6 months, a year. You can define all of these relatively easily because these are calculations based off the appointment data in your EMR. If you want to break them down by age, also very simple to do. There is a definite dropout rate. We talked about the single ventricles and how many of them we lose. So if you were interested in focusing down on an alive population, you can filter by vital status. It's very easy often to link it to clinics. So you can sort by clinic and look at only patients tied to specific clinics, which if you have a large extensive outreach network can be very valuable. And then the actual drop-down fields I alluded to earlier. So some diagnostic information, meaning does your patient have an ASD, a hole in the heart? Do they have subaortic stenosis? We did a 2-tiered system only because the list of total diagnoses within STS, as an example, the surgical database, was over 400, and it was organized as a single drop-down, which if you're trying to minimize workflow impact, asking people to sort through 400 diagnoses is a single drop-down, very cumbersome. But if you can lump that 400 into 20 main groups and then a few subtypes within the group, usually that gives you a lot more information and it's easier to sort through. And again, in our world, most of the providers are very, very familiar with the patient, so it's not like it takes a ton of time. You're seeing Jose Rodriguez, you already know he has a subaortic membrane that got repaired 2 years ago. It takes you 2 seconds to do LVOT subaortic membrane repaired, and you're done. That patient's now branded in your population tool, and you can track them over the course of their life and make sure that they come back for follow-up. You can sort by surgeon, you can sort by cardiologist, and then repair status is a good one for us. Only because children tend to outgrow any sort of implant we put in them. We don't have much, despite the PhD in tissue engineering and decades of research by people way smarter than me, we haven't yet come up with an implant that keeps pace with somatic growth. And so if we replace a valve or put a conduit in a 1-year-old, you're guaranteed that by the time they're 3 or 5 or 7, they're going to outgrow that. And you want to make sure they come back for surgery because the implications can be dire if they don't. So we have within the repair status, repaired, unrepaired. We also have implant requiring surveillance. Anyway, gives you just a feel for how you can kind of link time data from appointment scheduling to, age data, very simple fields in the EMR to a few simple drop downs and come up with some pretty powerful tools. Go next slide. So what you don't see in that dashboard, but what kind of runs behind the scenes then, is an algorithm that can assign statistical weights to the diagnosis or the repair status. So again, you can say a repaired ASD with no residual lesion. So a patient that had a hole in their heart that was surgically or catheter corrected, we would expect a normal life quality and lifespan for them. That's not someone that's going to come to the top of your list as a high urgent patient. Oh, they're a week past their appointment, we got to rein them in. Probably not. On the other hand, a single ventricle who's in between the first and second stage, there's in that 6 months between those two surgeries, 10% of them will die at home from arrhythmias or sudden cardiac death. They get seen every 2 to 4 weeks. And so if that patient misses one of their 2 to 4 week appointments, you're going to want to know about that pretty soon and jump them to the top of the list. So you would put a pretty high weighting coefficient on the single ventricle diagnosis, and maybe a multiplier on how many days since their last visit. You can tweak it to meet your specific needs, but the point is you can utilize what amounted to 5 or 6 drop downs, so 45 seconds of input once in the care of the patient, to capture a lot of information and then drive this stratification into who's at the highest risk. And then, to one of Jamie's points, you can do all that, but you don't want to do that in a 11,000 row CSV file and then hand that to someone and say, okay, run with it. No, you want something that's very user friendly, hopefully that integrates with your existing EMR, that's intuitive, so that you can hand it to your outreach team and they say, okay, look, this one's showing up in red, they're 1,000 days overview and they've got the highest weight. And then you move over to the open patient chart link, puts you right into the scheduling tab. They make a phone call, document the phone call, and hopefully bring that patient into clinic before they have a problem. So I believe that's a run through our specific example here at Loma Linda, but I'm sure we'll have some questions at the end. I think at this point, I'm going to turn you over to Dr. Bauta from Mercy First.
Thanks, Dr. Martin. That was a great presentation, sort of as far as, thinking through, exactly what you said is sort of, not just individual, but sort of population level, and sort of looking at health at a population level and sort of thinking through what does that mean? So obviously you want to have an impact at the individual patient lives, but the whole premise is that how can we improve, health across a group of individuals with different conditions? Next slide, please. So when you're thinking about population, you're looking at not just the individual, but groups, and you could classify that by different types of groups. And this can be stratified male or female because different conditions, impact individuals at different rates. Obviously, if you're looking at also demographics, younger children versus adolescents versus adults. And when we're looking at population health, especially in my division, we're looking at how can we improve population level outcomes. But outcomes, vary, like as I mentioned, by individual and by group. So in that case, I know that Dr. Betty Rabinowitz will be talking about this a little bit later, looking at the whole spectrum of, health. And this includes not only physical health, but behavioral health, as well as social determinants of health. So when we look at outcomes, or we look at different components as far as improving health, we're looking at genetic factors, we're looking at behavioral factors, we're looking at socioeconomic factors, as well as environmental factors. And each of those components are important as far as what patient comes in, right? As Dr. Martin said, you could have individuals that were diagnosed with a health condition, and for whatever reason, they, were lost to follow-up. But why are they not coming in? What are the barriers for that patient not following up? It's not necessarily that we could reach out to them, and we do in our behavioral health, and I'll share an example, that a lot of the times the reason they're not coming in has nothing to do with them knowing they need to, come in for, a follow-up. They know they need to follow up with, their primary care physician as far as sort of their regular, diagnosis and care. But the reason they're not coming in could be due to a variety of factors. Either, the group that we work with are usually disadvantaged populations, so they don't have access to transportation, or becomes a cost issue. for them to follow up, or they don't have the right sort of support or even the right information. And a lot of that, you know, as Jamie mentioned before, he didn't know that he needs to come in every 3 years for an echocardiogram or whatever other preventive procedure, because that information was not relayed to the individual. So they didn't really know the schedule of events they need to follow up. So when we're looking at population health, it's really important to understand, you know, from the provider perspective, which is our perspective, that we're providing that type of information and scheduling, but also from the other end, from the patient end, they understand there's a health literacy component, number one, but there is also follow-up, number two, and the importance is being relayed. Next slide, please. So when we think about health, it's very complex, obviously. We have a healthcare management program that kind of coordinates health, and, you know, Dr. Rubin will talk about this a little bit more, but as an individual patient, and, you know, my daughter was a patient of, you know, sort of having a healthcare and a heart-related issue. And it was overwhelming for me to sort of think about, you know, as far as what type of care she needed. And the type of system as far as what I needed to do. Obviously, when she was younger, she was, you know, diagnosed with a heart murmur, and it wasn't picked up initially by her primary care physician until another physician came in and did a whole battery of sort of, you know, preventative care measures. And she picked up something that the other, you know, primary care physician missed, because certain evidence-based sort of protocols were not followed, unfortunately. However, when the new primary care physician came in, when she took over, she did those battery of tests. My daughter got referred to a cardiologist, and then the whole fun started. One thing, you know, sort of from a personal, you know, caregiver experience is that how many systems does a patient have to touch? We got, you know, ordered lab tests for different things. You know, is it because at that time she was a little bit overweight? So we had to do, you know, lab tests. You know, I follow up with different types of specialists. In this case, it was a cardiologist. Obviously, he prescribed medication. She had, you know, even talking to the insurance companies, and depending on the condition, the patient might touch multiple different systems. So if you're coming into a hospital, obviously they'll do a battery of tests, but the hospital will refer you to others within the provider network. And sometimes that information does not follow the patient. That is one of the issues that we have within the healthcare sphere, that I wish it would, but a lot of times, if you go to hospital A, you get a treatment, you have all of that, you know, sort of information lab tests. Then you go to hospital B for another condition. You're, you know, again, essentially, you know, hopefully the hospital is transferring that information through, you know, different systems have interoperability now that they didn't have many years ago. But I did experience that, where I had to take that information. I remember even bringing a CD from one hospital to the other and thinking in my head, why am I doing this? And as a caregiver, I did that because I wanted to ensure that my daughter had the most optimal care. But as you could see within that healthcare pathway, that things usually fall off the tracks. And it really takes to have a diligent patient for them to sort of follow up and stay on that path of care, to realize that every 3 years I need to have an echocardiogram or whatever else that they need based on the condition they were diagnosed, and also have a caregiver along with a care team that actually follows up and ensures that individual actually follows up with a treatment regimen. And if you could take that, you know, sort of individual and all of the different systems that they touch and, you know, sort of increase it at a population level, the whole healthcare system has become much more complex, obviously. Next slide, please. So when you're thinking of population healthcare management, and I'll give you one example from our organization as far as our healthcare management, we're looking at what are the structures as far as program design and governance. Our healthcare coordination team, we decided to, you know, restructure the way we were working to ensure that every single patient that came in within our organization has the most optimal care, but also they follow up with their treatment regimen, number one, but as well as their provider network, number two. So for us was basically to structure how each patient's experience looked like. If they're coming in to get a more comprehensive approach regarding, you know, what type of condition do they have? What types of services are they targeting? And, what does their health and mental health condition look at that point? So even structuring the way we were collecting information, tracking that information was important for us, as well as standardizing that information. So for us, the next step was, that we have at least 300 patients that we were following up at any point in time. That number one is to get the information across the network for that patient so that we could do the most optimal care coordination. Second point was to integrate all of that data, so then we had a pretty good comprehensive view of what are the next steps as far as their care. And then, as Jamie mentioned, just having the data is not enough, but making the information actionable. So figuring out what are the next steps as far as follow-up are absolutely key. So it's not just having the data, but analyzing that data and making it useful so that there's sticklers in the system that highlights as far as what are the next steps, and also triggers the care provider as far as follow-up or the care coordinator that this is the next step as far as that treatment process for them to follow up on. The whole point is that we want to provide a holistic, patient, centered, care management approach that integrates multiple components or disparate pieces of information. And obviously, the most important is that it's patient and consumer focused. That I want to ensure that you're able to follow out your treatment regimen. And my treatment regimen or my daughter's treatment regimen is very different from another patient, and ensure that that is followed up. And obviously, the most important thing that we would like is that in case of my daughter, that I don't have to have, a more utilized higher level of services, that preventive services, and I'm following up with that approach, and I'm seeing those outcomes. So it's important to have those important components as far as you're thinking of population level management. In our healthcare management approach, what we've done is that we built an algorithm that kind of stratifies risk. So each time a patient comes in, they take this questionnaire, and then it stratifies their risk, their health, their physical health, and social and emotional aspects. Once we determine that, based on that algorithm, then we could see that we'll stratify the patient if they're high, medium, or low risk. If they're high-risk patients, then the care for that patient is much more intensive, because we want to ensure that those high-risk patients are being treated, much more intensely, number one, but also follow up with their regimen, faster, and ensure that it's much more consistent over time. Next slide, please. The reason that we want to do that with the high-risk patients is that we want to ensure that not only do they receive that treatment and they follow up, but they're not utilizing higher level services. So in our managed care universe, and my colleagues talked about this, we're desensitized, there's less incentives for utilizing higher level of services. So the more that we could control the condition and move the patient downstream to utilize, more preventive services or follow up with their treatment regimen, it's really important, for us as an organization to control costs. So the way that we do that, obviously, Jamie talked about this, is taking all of that information from our healthcare management team and using that to sort of analyze that data and use that information for decision making. Next slide, please. Obviously, for any organization, even our organization, there's 3 different buckets. One of that is that we would like to minimize costs. We definitely don't want to increase costs, not only for the patients, but also for the organization over time. We definitely want to have an operational and organizational impact. We want to have individual client impact as well. We want to diagnose the conditions early, and if they're diagnosed early, to provide the right and most appropriate treatment. We want to ensure that our systems are effectively engaged and they're followed up on. And the whole point of that is that for the organization to also have a business impact as well. Obviously enhance patients' experience, but also as Dr. Martin has said, for organizations as well to stay in business, definitely want to increase revenue, but increase revenue in a way that puts the patient and the patient focus first. Because for us, the reason that I'm in healthcare is that I want to ensure that everybody that I come in contact with have the right outcomes, and that is really key for any healthcare organization. So with that, I'm going to, transfer it over to Betty Rubinowitz, which is going to talk much more about social determinants of health and sort of looking at from a population level.
Thanks so much. It's interesting to see the path that we have followed through the presentation and where the things I'll talk about fit in. And I think what we've done basically is taken different vantage points that look at the same question from different clinical use cases or different views or approaches to analytics. And next slide, please. What I would like to focus on a little bit is the use of social determinants health data to improve patient outcomes. And in recent years, I think everyone is aware there's been increased focus on social determinants of health and their impact on outcomes. And in many ways, this renewed focus has mirrored the advent of more evolved, more sophisticated population health applications, as well as evolution of the whole discipline of population health. And it's been this ability to focus on social determinants has been facilitated in part by the availability of multi-source data. We now can look at electronic health record data, administrative and claims data. We can look at HIE and health information exchange data, and of course, social determinants data, now that we have figured out ways to collect that data, measure, and analyze it. To my surprise, it took 41 years after George Engel at the University of Rochester postulated and proposed the biopsychosocial model for the American College of Physicians to come out in 2019 with a position paper that clearly stated that the impact of social determinants of health is significant, and that the role that they play where someone is born, the social circumstances they're born into, has significant impacts on their lifelong health outcomes and ultimately their health expectancy. Sir Michael Marmot is a British epidemiologist who has done foundational, outstanding work in this area. He wrote a book called The Health Gap, The Challenge of an Unequal World. And that is a foundational reading for any one of you, the listeners who's interested in this space. I highly recommend it. But he basically said that inequities in power, money, and resources give rise to inequities in the conditions of daily life, which in turn lead to inequities in health. And that basically, in a nutshell, it beautifully summarizes the issues and the importance of us beginning to grapple with collecting, analyzing, and utilizing and impacting our clinical decisions with social determinants data. So in Sir Marmot's work, he started doing work in London, comparing the outcomes in affluent neighborhoods and those in less privileged neighborhoods. And eventually, he found an incredibly helpful way to describe the difference in these outcomes. And he did this by describing the British tube, the underground in London, the subway, and came out with a calculation that showed that for every mile down the subway track that you go from an affluent neighborhood to an underserved, underprivileged neighborhood, for every mile, there was 2.6 years in life expectancy that were lost. And ultimately, when you went from the rich neighborhood to the furthest point on the underground or the subway track to a poorer neighborhood, it resulted in the longest life expectancy at a gap of 21 years in life expectancy. That is a staggering number when you think of it. The Virginia Commonwealth University replicated the study and showed that on the Green Line in Chicago, which is under the subway, one of the known subway lines in Chicago, there is a 16-year difference in life expectancy between the center affluent neighborhoods and the furthest points in underserved neighborhoods. So clearly, there is irrefutable evidence that social determinants of health impact in the most meaningful of ways life expectancy, life and death, the outcomes of patients. Next slide, please. Another way of looking at this is looking at excess deaths, and this data is an example year. This is actually the year 2000. It's likely just has either stayed the same or gotten slightly worse since then. And you can tell that factors such as low education by itself, isolated to just reviewing that impact, is responsible for 245,000 excess deaths in 1 year. And what I found really remarkable was that 162,000 excess deaths in the year 2000 were attributed to low social support, or if you will, loneliness. And we know the importance of social support and loneliness. You know, we've come out of a long year of an epidemic where we were encouraged and reminded to reach out to isolated and less supported members of our neighborhoods, our cities, and our kind of social fabric. And the reason that it's so easily understandable is that in excess of 162,000 deaths is more than the deaths per year for the year 2000 from lung cancer, which is one of the leading causes of death and is referred to often as an epidemic of a cancer-related diagnosis because obviously of its correlation with smoking. When you think of it, the irony that smoking and smoking cessation are also very tightly related to socioeconomic capabilities and abilities. Next slide, please. So the speakers before me all related to a certain approach that they have taken to analytics. And I just wanted to share with you kind of in a general sense, another way of looking at analytics as a whole, and that is to think of analytics as descriptive, predictive, and prescriptive in nature. And some of the examples we heard today were descriptive analytics, so the ability to create a registry of kids with certain congenital heart defects, or look at preventive services, or treat an individual patient with gaps in care or required treatment. And descriptive, with a D, analytics allow us to count things, to describe them in very basic terms in healthcare related to diagnosis and demographics and age and gender, location. You can see an example here in one of our population health sections. We divide patients by a geospatial map, so you can see the regions that they come from. And when you think of the example of the subway stations, being able to geospatially describe your patient's distribution becomes extremely important. But that all is in the realm of descriptive analytics. Predictive analytics builds on the data that you have collected, synchronized, normalized, standardized from multiple sources, and begins to apply more sophisticated statistical algorithms to it in order to be able to say, when these conditions exist in the descriptive realm, we can predict that these particular outcomes will result. When you get to prescriptive analytics, you're really going one step further and allowing the end user of the analytics to manipulate the data to create what-if scenarios. So if our diabetics were on average better controlled, what would that do to our performance in a value-based contract would be a very simple question. And a more sophisticated question is, what would that do to our health outcomes as a whole, mortality rates, complication rates, and such. We have done as an industry a pretty good job with descriptive analytics. We are very fortunate to have some very powerful predictive algorithms that are being applied with nationally standardized and reproducible risk algorithms. We are way behind other industries like the financial industry and such with prescriptive analytics, where we can truly offer clinical teams the ability to manipulate and look at what-if scenarios, and that's a lot of work has been focused on that to try and improve our prescriptive analytic capabilities in healthcare as a whole. Let's look at one specific type of data, which is the social determinants of health data, and figure out how it fits into this construct. Next slide, please. So how are we doing with social determinants of health as a data type and a data capability? Where are we on that spectrum? So in 2019, JAMA, the Journal of American Medical Association, published an article that found that most of the US physician practices and hospitals are screening patients for at least one social need. And interestingly, it surprised me somewhat, but the most often screened need was experienced with interpersonal violence. And the reason is that all hospitals will screen patients coming in. Many offices have gotten pretty good at that, but that's it. When they looked at the rest of the components and the domains of social needs, the results were pretty abysmal and showed that really when it came to food security, insecurity, housing instability, utility needs, transportation needs, and that the most practices were not yet addressing those whatsoever. The silver lining in that data was that federally qualified healthcare centers were doing a much better job than other practices in this regard for many reasons to do with their structure, their ethos, their culture, their focus, and that there about a third of patients were being screened for all 5 CMS-defined domains. And more encouragingly is that practices that were participating in any type of advanced practice models, value-based contracts, either an ACO, advanced primary care model, bundled payments even, that the numbers there were improving as well. So that value-based care and the requirements for participation in those were encouraging practices to begin collecting the data. How the data is collected varies. We at NextGen have selected and partnered with Prepare. Part of it has to do with our deep support of the federally qualified practices. So this is a tool that screens multiple domains and the ones that I mentioned, but there are other tools. These are that are available. There's a tool called Health-Related Social Needs. HRSN is the acronym. It's a screening tool published by CMS that looks at all of the domains that I mentioned before: housing instability, food insecurity, transportation, utility, and violence. And then there's another algorithm called Health Begins. I chose randomly some of them, but clearly there are tools available that are now relatively easily integrated into the EHR workflows or population health tools. For example, one of the things we've been able to do is embed it across the continuum of platforms. Patients can see it, fill out, prepare a questionnaire on their pre-visit, log on to the patient portal. We have it embedded in our population health care management module that allows care managers to ask these questions. And interestingly, when you do research to find out how are patients more likely to respond to these questionnaires, responding in person, responses are apparently less forthcoming and less honest than they are when the patients are given the opportunity in the privacy of their home, on their phone or a tablet, to actually answer these questions because of the stigma attached and shame associated that patients feel acknowledging that they're struggling in these domains. What's very exciting to me is that we now in our care management tool have allowed through a decision support engine, helping care teams to actually quickly ingest this information from these screening tools and act with a recommendation on a referral to social work or any other workflow that the organization desires. Next slide, please. So this is really a summary of if your organization is considering beginning to tackle this challenge, and I certainly hope that that is the case, so that you're halfway down the road or have arrived already, which then kudos and congratulations to you. But as you know, it has to do with, first of all, you have to ask the question, collect the data. Strongly recommend that you choose a nationally available, validated survey tool and screening tool. What you want to be able to do is have comparable data that allows you to analyze against benchmarks, and the only way to do that is use a uniform, standardized and normalized data set, and using one of the national tools is essential. Integrating and analyzing the data obviously takes some effort, but you can start at a descriptive level. If you have the tools to do predictive analytics on that, the more the merrier, and eventually we will have prescriptive analytics. In some ways, we at NextGen have jumped a little bit to the prescriptive even before the predictive, just to help groups be very capable of operationalizing the data. Because allowing decision support, automated decision support, is clearly a way to scale and act on all of this data more effectively. And lastly, one of the biggest challenges, and all of the folks before me touched on it, we have to figure out ways to share this data across a continuum. Social determinants of health are not a medical problem. They're a policy problem, they're a political problem, they're a social services problem, they're a city and town hall problem, they are a government, they're a state authority problem. We will all have to communicate, integrate our response in order to make headway on these. And the only way to do that will be to share this data effectively. We cannot be asking patients to answer these difficult questions every single place that they go. We have to figure out that we do this on a cadence of once in 3 months or once a month. And if you answer these questions anywhere across the service continuum, that information will be available to other service providers so that they can act on it without tormenting the patient with answering these questions multiple times and not sharing either the response to the questions or the healthcare system's reaction and workflow that resulted from those responses. I'm sensitive to time. I am going to yield back to Michael to take us through the Q&A part of our conversation.
Thank you, Dr. Rabinowitz, and thank you, everybody. This was an awesome presentation. It was a lot learned, and it was well received. I do have some questions that I just wanted to pose in our Q&A session. I'll pose them to one of the panelists first, and then we will open it up for everybody. So, Dr. McLaughlin, to start with you, there are so many tools available in the market for analytics. how should we strategize on what is the right solution for us? And when I say us, it could be hospitals, it could be any type of organization. So I'll start with you, and then we can open it up to the other panelists.
Sure. So if we're talking about somebody doing their analytics journey, I think there's really two types of tools that matter, right? There's the tools to organize their data, and there's the tools to visualize their data, make it consumable to the client. So the first thing I'll say is tools aren't the most important thing. Sometimes they're really important because we want a good picture that makes people understand. But if a organization already owned a business intelligence tool, unless they have a real dissatisfaction with it, I would say we use it. If they don't, then it's a question of ability to support it, and cost, and security. And there are several different tools that we can work with that our clients use pretty regularly. From a database point of view, it's sort of the same thing. A lot of organizations invest in some of the more scalable ones that you've heard of, things like Microsoft Azure and Snowflake and AWS. But at the same token, if you're just getting started and you have a database for some other purpose, we can utilize it and use that to grow the data. So what I do think is important is that the solutions aren't siloed. Now, there may be times when you have to add silos. Like, we have a pretty good process intelligence solution. There are some finance tools out there that are better than anything I'll figure out because I don't have an accounting degree. But if you're really trying to do analytics, then the goal would be a universal business intelligence tool. There's lots of them that you've probably heard about, Power BI, Tableau, whatever it is, and a universal cloud-based. If it's not too much risk for you, we would normally recommend a database system. And then what you do is you work together to create a roadmap to get a little bit of value out of that and a few users, and then show, look, we had this ROI, this is better. And then you have more users and you pick another project and you get more value out of it. So you get short-term wins, but you're building a long-term foundation as you're putting more sources of data in your enterprise data warehouse, and you're getting a common look and feel and regular users for your business intelligence tools. So I think that's the real message, is to get it up in a way that you can grow it slowly over time, and that you're growing it in one place. You're not adding silos. You're taking a scalable data warehouse or a scalable data mart and a business intelligence tool, and maybe you start with 5 users in one use case, but you can grow it over time.
Hey, Michael.
Yes.
I'd just like to add to that something that Dr. Martins spoke about in his comments that I think is really important, irrespective of what you choose and what tools, etc. The importance of being able to integrate this information into the EHR or the point of care. Because what we have learned is that clinicians, Dr. Martin said he wouldn't spend another 2.5 clicks on adding something, and he's good because most clinicians would say they wouldn't spend another 1 click. So having the data at the point of care available where clinicians, care team members do their work is absolutely paramount. You can have the fanciest analytics tool in a dark room somewhere. If it's not used, it doesn't matter.
Yeah, I think that's a critical point. After I presented our drop downs and the kind of the vision to our group of 15 or so providers, and they all said, "Oh, this is great. We love it. Let's do it." Probably for about 6 months, the only people actually adding patients into the registry were myself and the NP, to the tune of about 1,500 of them. And then I finally, they didn't like it at first, and I got some nasty emails, but I embedded the drop downs so that you could not close out a clinic visit without selecting them, which, again, for about a month, some of the less receptive people were constantly sending me emails, "I can't close my clinic visits, I can't close it." But, once they realized that it literally just meant 2 drop downs, 2 clicks, and then that went away, and they stopped getting harassing messages from billing. If you can insert it into the workflow while they're seeing the patient at a time when everything is primed, and it literally takes, I mean, I'm not joking, 20 seconds, bam, 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 bam. We went from having 1,500 captured patients to like 6,000 in less than a year, because again, your providers were almost forced to do it. And the benefits, it's like everything else. You try and teach people a new process, they never want to change, they never want to do anything new, and then a year later they're looking back saying, oh, why didn't we do this earlier? So working within kind of the confines of what you have available, but making it easy, but obligatory, I think is the right word. Don't leave an out or a workaround, and you'll get uptake.
I think, as I know, as Dr. Martin said, it's really important to sort of build with your existing clinical workflows. I think when you start adding something new, it just becomes too much as far as the learning curve. So what we did is that we took our existing clinical workflows and just optimized those. Sometimes starting off, even looking at your EHR and seeing what can you do. So if our clinicians, our physicians are there, I want to make their life easier. So they're clicking fewer clicks rather than more clicks. It's within one window rather than having them navigate multiple windows. And then bringing the insights back into where they work. So if they're within the EHR, surface those insights within the EHR so they're not going to another system. I don't want to have them to go to the Power BI dashboard. Why can't you just feed that directly into your EHR dashboard? So if you're logging in, if you have a standard workflow that you want to optimize that or streamline that rather than just creating additional, workflows.
Thank you, everybody, for your input. I think that was really great. I do also want to be mindful of the time too, and I'm just trying to get to folks' questions. So thank you on that. Dr. Martins, you gave a great detail about your experience with your analytics at your organization. How did your organization come up with the KPIs? Was that something that you did at the physician level? Was that something you used from a best practice? How did you guys come together with what you wanted to use analytics for?
Educate me. What's a KPI?
Sorry. So key performance indicators. Sorry.
Okay. So I guess it was a couple of things. So we were making the argument that by diagnosing and then making sure that the patients with congenital heart disease were appropriately plugged in, and then following up and getting their echoes every 3 years or 1 year or whatever. And then more importantly, when they were falling out of range or not getting the tests that they needed or being seen, getting alerts generated. It had a couple impacts. We tracked our overall catheter, cath lab and surgical volumes, which have risen every year for the past 5 years. We looked at the percentage of patients that we had flagged and entered in and said, okay, this is your congenital heart disease diagnosis. What percentage of them fell outside the window or were overdue for follow-up? And, we gradually saw that go from 25% to 23% to 22%. Those are the main things we looked at. Through the SDS, we tracked mortality overall, and there's been improvements in that. Now, obviously, this is all more correlation than direct causation, but everything gets linked together, if you ask me. If the patients are not lost to follow-up, if they're seen in a timely fashion, if they receive the proper education at those visits, if the communication is good, if they're engaged, all the things we talked about. If you're doing those things, it's going to translate into better outcomes. And if you're not, it's going to hurt you.
Great. Thank you for that. Dr. Bauta, this was another question that came through. What are the challenges with moving towards analytics with population health focus? In your experience, what are some of the challenges, maybe sourcing the data, partnering with agencies? What has been your experience that makes it difficult?
So for us I'm so glad that, sort of nationally, we're moving more into interoperability and ensuring that the different systems are able to talk to each other. I know, as Dr. Rubinowitz said, it's like we have patients that are coming into one system, sort of, having our healthcare providers and ask all these questions, and then they go somewhere else and have to answer the similar types of questions. there in New York State, there is a state healthcare information exchange network. It's called Shiny for short, where we enter the information within our EHR. That EHR gets linked with New York State, sort of regional health information network, and then we are able to tap into that directly with our EHR to get that patient data. So in a way, some of those systems are becoming much more optimized, and then the patient information is following the patient. Much more can be done related to that. I mean, that definitely helps with our clinicians and our providers if a new patient is coming in, or if an existing patient is coming in, let's say, whatever they went to, for their physical, checkup. And then, 2 days ago, they had gone to a hospital, but it's not within our system. That in a way, if a patient mentions that, doesn't mention that, it kind of pops in as an alert directly within our EHR. So for example, our clinician can follow up and say, you were in the emergency room 2 days ago, what happened? And then they could do that additional follow-up. They're still, nascent as far as sort of the interoperability, but we're getting there. And there is definitely different systems there, are being put in place by the city-state, including the EHR vendors, to make that exchange, much more seamless across the different systems.
Great. Thank you. And Dr. Betty, one last question that we'll take with the time we have left, and then we'll wrap everything up. You mentioned prescriptive analytics and how they are not widely used in healthcare. Do you think this is because physicians do not trust the analytics? How would you advise health systems to mature towards the prescriptive analytics?
My sense is I don't think this has to do necessarily with physicians' trust of data. I think that we have made some great strides with more accurate data, more accessible data, more user-friendly data, and that physicians actually are data-driven creatures by nature. And once you present them with good data, they'll use it and adopt it and see the benefits of it. I think Dr. Martins spoke to that as well. I think the issue is more the evolution of the systems that support healthcare, some of the more sophisticated modeling algorithms are being developed as we speak. I think it's just a developmental stage that we will pass through quite quickly.
Thank you so much. I do know that we're over our time a little bit, so I just wanted to make sure we got a question to all of the panelists. So thank you, and thank you to our panelists for joining us today. Nick, we can move to the next slide. I really appreciate everybody that has been able to attend today's event. I hope that you were able to enjoy it while having a scrumptious lunch, and that we really hope to see you back here in the future. As Tony mentioned early on, this was an RSM US LLC sponsored event. Nick, if you want to move to the next slide. And so I have all the contacts for all of our panelists here. If you'd like to get in contact with us and learn more about analytics or have any follow-up questions that we did not get to answer today, please reach out to us. I will get you in contact with the appropriate panelist, and we look forward to connecting with you. Analytics is key in healthcare now. It's moving forward in our industry. It's becoming part of our everyday life, and we want to have these conversations with you. So thank you so much for being present today. And Tony, I'm going to pass the ball back to you to wrap it up.
Michael, thank you very much. Great job by everybody today. And I want to thank RSM for being able to sponsor today's event. That was fantastic. All of our speakers, great job. This recording will be available within the next 48 hours. It'll be up on our YouTube channel. So we will publish it out to all of our members so they can log on. I would also suggest that if you folks have some time on the 22nd coming up, we have an update that is going to be from the folks from ONC and CMS. What's going on with today after the COVID hit, and what is our government doing? So come and join us at that event. Next slide, please. And again, thank you for your time and attention. One more slide. We're always looking for folks to be able to come and join us. Sorry, I thought we had one more slide left. I apologize. But please come and join our chapter. These events are fantastic, and I appreciate everybody's time and attention. Have a good day. Stay healthy, stay safe, everyone. Thank you. Bye now.
Thank you.